Hi, and welcome to AAHPO's American Armenian Health Professionals TV health program. This is the second part of breast cancer. We were conversing on last program with Dr. Amber Guth about the breast cancer diagnosis, and now the second part will be the treatment of the breast cancer. Dr. Guth, welcome again to our program for second part of the breast cancer. Now that we know the recommendations for the diagnosis and possibly the prevention for the breast cancer that we spoke before, what is the treatment now? Let's say somebody comes in and has breast biopsy, needle biopsy or surgical biopsy, and has breast cancer. Obviously there are different types of stages. Let's talk about the breast cancer. What's the treatment in general?
Our thinking about breast cancer has changed greatly over the last 15 to 20 years, and we really emphasize these days the biology of the specific cancer. And we know that there are different subtypes of breast cancer, and these act very differently. Some are more aggressive, some are less aggressive, and we need very different treatments for the different types of cancer.
Right.
So
let's think about,
yes.
let's talk about first the hormonal positiveness and negativeness, which is in the picture.
Right. The majority of breast cancers in this country, probably about 2/3, are what are called hormone sensitive or hormone positive.
Which is a good thing.
It's a good thing. And it doesn't mean that the woman is overproducing estrogens and driving or feeding this cancer, but it's telling us really about the sensitivities and weakness of the cancer itself.
Right. So that they respond better actually to treatment than if they are hormone negative.
That's right, because we have what's called targeted therapies, and that's the emphasis on breast cancer treatment these days, really looking for the weak spot, the Achilles heel, so to speak, of that cancer, and aiming for that. Not treating everything, not treating with everything, but treating with the right thing.
Right. What is the genetic testing and importance in breast cancer?
It's extremely important, and the role of genetic testing is changing greatly. There's been a lot of publicity since Angelina Jolie publicized her genetic abnormality and tendency for breast cancer. There's been a much more awareness. Over the last 3 years, we've been able to test for many new genes as well, not just the breast cancer genes, not just the BRCA genes, but we have what are called wide panel testing now, where we can test for up to 27 to 30 genes that have some influence on breast cancer risk, but also other cancers, colon cancer, melanoma, thyroid. So women with
individualizing treatment now started since we started to check within the genes.
Yes.
And it becomes a little difficult issue in the offices for our patients that who should really we recommend that should get genetic testing, because it's not going to be done easily and readily available ways. Some people don't need it, some people need it. Who should we recommend?
Women with a strong family history. Again, first-degree relative, multiple members with breast cancer or ovarian cancer, family member, individuals who have particularly aggressive cancers, what they call triple-negative breast cancers, women who themselves are diagnosed in their 20s or 30s. These are all women who are at high risk for breast cancer.
Right. Let's talk about the surgical treatment now for the breast cancer. Now we have the diagnosis. We have, let's say, lump 2, and the size is important?
The size is important, but just like real estate, location. Location.
Right.
This very much determines our treatments, because you may have the same size cancer in 2 women, and one may be amenable to lumpectomy, and another woman you may end up with a very disfigured result. So some of it really depends just on what your cosmetic results are.
Where it is, where it's located to the nipple, I guess, and
that's right.
And how depth it is in the tissue to
and
the skin.
And how big the breast is as well.
Right. So let's say we can do lumpectomy.
Okay.
You do lumpectomy, and the results obviously then is get determined if we're going to do some chemotherapy and radiation treatment.
That's right.
So how do you determine that?
Right. Well, breast cancer has very much become a multidisciplinary field. So none of us make these decisions on our own. We make it in conjunction with the radiation therapist, with the medical oncologist. So we work, and the breast radiologist as well. We work as a team. Again, looking at focused and targeted therapy, we're trying to use less and more focus less treatment if possible. Many patients who, up until a few years ago, would have been recommended radiation for stage 0 non-invasive disease, now we're rethinking that and we're testing these patients differently, and many of these women may not need radiation.
Now, is the location good and this lesion is small and we can do lumpectomy? How about lesion is really big and then is in another spot that we can do lumpectomy and we do mastectomy? Let's talk about the mastectomies.
The role of mastectomy has become a little bit more complicated. You know, there's a lot of concern within the medical community because the rate of prophylactic mastectomy has been rising in the United States over the last 15 years. And we want to make sure our patients are making informed decisions and good decisions based on their health and outcome and not based on fear. So it's very important to have a long, open discussion with the patient at the time of diagnosis to help them determine what's the best route for them.
So the reconstructive surgery starts at the same time of general surgery when you do mastectomy, or?
Yes, usually we work together.
Right.
Unless it's a very advanced case, sometimes with our very large and aggressive cancers, the patients may get chemotherapy first, may get the mastectomy, radiation, more chemotherapy, and then we bring them back a year or two later. But that's for the very advanced cancers. The more common cancers, we try to do everything together.
At the same time?
Yes.
And usually it takes a couple of months to recover?
A little faster than that, actually.
Yes.
It's usually about 3 to 4 weeks to get back to work, about 6 weeks to feel comfortable, about 3 months to feel completely yourself. But people can really get back up on their feet very quickly these days.
If they have the mastectomy and they had reconstruction, how often they should have mammogram?
Never.
From there on?
Never. You know, once you've had the mastectomy, we follow them by physical examination, and they don't need routine imaging.
How about the other breast?
Again, they should be getting at least a mammogram and probably an ultrasound yearly, maybe an MRI, depending on their history.
Yearly on until?
Yes, until they stop.
Dr. Guth, thank you very much for this very informative information. We'll ask you to come back again for another program.
Thank you very much. It's been my great pleasure.
Now it's time for this week's article. It is citrus fruits, arterial stiffness, and heart disease. The incidence of cardiovascular disease rise sharply after menopause. Arterial stiffness, which is generally related to blood pressure, is one of the risk factors for cardiovascular mortality. Although arterial stiffness is a consequence of vascular aging, it can be reversible with physical activity and dietary changes. Flavonoid-rich foods like citrus fruits have anti-inflammatory, anti-atherogenic properties and have been beneficial effects on vascular stiffness, insulin sensitivity, and blood pressure, which are all risk factors for cardiovascular disease. Flavonoid-rich orange juice consumption has been shown to lower blood pressure. A large study examining the links between flavonoid intake and cardiovascular disease mortality in postmenopausal women showed a statistically significant inverse association between flavonoid intake and cardiovascular disease. Recently, a team of researchers from France studied the effects of grapefruit juice consumption on vascular function in healthy postmenopausal women. 50 to 60-year-old women were given 12 ounces of grapefruit juice for 6 months and were evaluated for blood pressure, arterial stiffness, and vascular function. This study showed that arterial stiffness was statistically significantly lower after consumption of grapefruit juice. Eat orange and grapefruit, which contains large amount of flavonoids, and decrease your chance of getting cardiovascular disease and stroke by decreasing arterial stiffness and blood pressure. Don't take any medication with grapefruit juice because they may interact with the metabolism of many drugs, including vitamins. Have 2 hours in between taking any medication and eating grapefruit or drinking grapefruit juice. Good health is precious and priceless. Pay attention to your health and keep informed by visiting AAHPO's website, AAHPO.org. I'm Dr. Karatoprak. Until next program, so long.